Moving on to device therapies, Heart Rhythm 2021 had a lot of focus on physiological pacing. And physiological pacing basically means trying to engage the septum during pacing. The Chicago group presented on patients who underwent a regular pacemaker, which is traditionally positioned in the apex of the right ventricle, and compared that to patients who had left bundle pacing, where the pacemaker lead is positioned higher up and actually screwed into the septum so they can engage the left ventricle conduction system. And they found that there were 300 odd patients in both arms, and the left bundle pacing outperformed the RV pacing over 2 years of study enrollment. And this translated to a reduction in mortality and heart failure hospitalization and upgrade to a BiV device. It's important to note with every study, there are some limitations. This was a non-randomized study. The bradycardia indication was unclear because bradycardia can really come in different flavors, whether sinus node dysfunction or AV block. But patients who derived the maximum benefit from physiologic pacing were the ones who were pacing the most, which makes sense. So I think this opens up an interesting area where should we as a field be moving away from right ventricular apical pacing? Again, it's non-randomized, but the signal's there, the procedure, I do this procedure, it's relatively safe, it adds a few extra minutes, but if it's the right thing for our patients, it could save them a lot of trouble down the road. Another interesting poster was comparing left bundle pacing versus non-selective left bundle area pacing. And I think this is important because I think we have upwards of 6,000 doctors who put in pacemakers and defibrillators in the US alone. And to have everyone go through the training or the different processes to get selective pacing versus non-selective pacing is an important question. And this poster had about, I think, 30 odd patients, and they found that non-selective pacing fared just as well as selective pacing. And if this is confirmed by further studies, then I think it could really increase adoption across the country and possibly across the world. Another study which really caught my attention and was a late-breaking trial was looking at long QT syndrome in young women who were on oral contraceptive pills. We all know that hormonal flares are bad and they can trigger arrhythmias. And historically, I always thought estrogen was responsible for this. But when they looked at a large registry study where there were, I think, over 1,500 patients, 22% had long QT. And they looked at the impact of oral contraceptive pills on long QT syndrome. The investigators found that progestin only had the worst cardiac outcomes. But what was reassuring to me is that beta blockers really ameliorated this effect and brought the risk levels down comparable to patients without long QT. So for me, if I see a young woman with long QT who's on a progestin-only oral contraceptive, one, I would question if she can be changed to something else. Two, I would make sure she's on a beta blocker. And the registry also found that long QT2 specifically lended to a much increased risk. So that population, I might even shy away from oral contraceptive pills. So I think that study was also practice changing for me. So I think one of the areas that we are fumbling with in EP is atrial fibrillation ablation procedures, especially for patients who have persistent or long-standing ablations. And the reason for this is the STAR-AF trial told us that pulmonary vein isolation is very effective in paroxysmal atrial fibrillation. But we know that these procedures at best are about 60 to 70% effective. Maybe 80% of patients come early. But what about the remainder? Our technology is top notch. We have we have ways to create durable lesions. We have a lot of different energy sources that are available. What we don't understand is in patients where the triggers are outside of the pulmonary veins, where are they coming from? And a very interesting study that my colleague, Dr. Haynes, presented at a late-breaking session at Heart Rhythm Society was using electrocardiographic mapping. And there have been several attempts in this area. This is not the first of its type, but this is unique in that it shows us dominant sources and can potentially point us to different triggers, which maybe if we target them, we could improve our success rates upwards to 90% or so. We really need to close that gap and improve our understanding on non-pulmonary vein triggers. So as someone very excited about new advances, I think this gap or lack of understanding is an area that we should be looking at in the next year. We will be starting a clinical trial on this at Beaumont, and hopefully we should have more results for HRS 2022. On another note, I think for conduction system pacing, I would encourage my friends and colleagues across the country to start picking up on that. I do think that it's relatively safe, it's relatively easy to learn, and it could really be a game changer for our patients. And finally, I would say for patients who fail cardiac resynchronization therapy, there is an endocardial left ventricular pacing system that is being investigated right now. It's called a SOLVE CRT trial. We just got site acceptance yesterday. And I think this could be a game changer for patients who are not candidates or are not responders to cardiac resynchronization therapy and could open the doors for a lot of patients with heart failure. Also, in the setting of the AF study that was recently presented for permanent atrial fibrillation, patients tend to benefit more with CRT and ablation. And if CRT is not an option, having an endocardial LV pacing system could be another bailout option for these patients. The early results from Heart Rhythm Society 2021, where they looked at 31 patients, seems to suggest that across 19 centers who were implanting it for the first time, they had a relatively low procedural complication rate with an improvement of ejection fraction of about 5% and reduction in volumes, LV cavity volumes, by about 20 cc's. So, and this is just a roll-in trial. So I expect with adoption going up across the country and the learning curve getting better every time, we will be very soon able to offer this to our patients.